Assalamu alaikum. This presentation is on the management of about one-third of laryngopharyngeal reflux patients who do not respond to the standard LPR management plan. The medical literature suggests that between 10 to 40% of LPR patients don't adequately respond to the standard medical treatment for LPR, including PPI therapy. We also know that just less than half of the patients of LPR don't actually adhere to the correct dosage, duration, or time of the day intake of their PPI. In dealing with patients who are non-responders to the standard medical treatment of LPR, 5 issues would need to be considered. Is the diagnosis correct? Could it be anything else? Is the treatment adequate? And is the patient complying with it? These are the first 3 issues. And then, does this patient require any extra specific medications out of these 6 new groups of medications, including things like prokinetic agents or mucosal protective agents or gastric-retained bile acid sequestrants? And finally, whether there is a need for anti-reflux surgery to control the patient's condition. LPR patients present with a clinical picture of upper aerodigestive tract irritation and inflammation. These features are also common in other conditions, including upper aerodigestive tract allergies, chronic rhinosinusitis, mouth breathing, obstructive sleep apnea, active or passive smoking, and also other conditions like esophageal dysmotilitis, for example, or food intolerance, including intolerance to lactose or gluten or food allergy. In order to answer the question, is it LPR or not, other investigations may be needed, including a trial of a 24 hours impedance pH monitoring. This time it should be carried out with on treatment rather than stopping the treatment for 3 weeks before the monitoring, because this would tell whether there is any residual active acid reflux or a non-acidic reflux, including even alkaline reflux, and the number of episodes and whether it is upright or during sleep. The other thing that should be considered is a flexible esophagoscopy to rule out other conditions like hiatus hernia, xenophilic esophagitis, Barrett's esophagitis, or even tumors. And in some cases, manometry, esophageal manometry, may be required to establish whether there is any dysfunction of the upper or lower esophageal sphincters or any esophageal dysmotility, which may be found in about 22% of non-responders. The patient may be given the right treatment and the right advice, but he may not necessarily be complying with it. One study found that only 8% of patients took their PPI therapy 30 to 6 minutes before meals as prescribed. Also need to check whether the patients are complying with the diet advice and lifestyle measures, whether they have stopped smoking and stopped consuming certain beverages like alcohol, coffee or tea, carbonated drinks, and fruit juices. The sleeping position is also important. The head of the bed should be elevated about 15 degrees, and it's also worth checking whether the patients are taking their medications in the right dosage and for the right duration and in the right time of the day. Following that, all the patient's medications should be reviewed, because some medications would actually prevent the success of medical treatment to LPR, including things like statins, angiotensin converting enzyme inhibitors like, for example, ramipril, selective serotonin reuptake inhibitors, calcium channel blockers, antiplatelet like clopidogrel, and certain antibiotics like clindamycin or doxycycline, and oral iron, non-steroid anti-inflammatory drugs including aspirin and ibuprofen, thiophelin, and nitrates. It's worth re-advising the patient about diet and lifestyle modifications to control their LPR condition. Patients should be given information leaflets about all these measures and also directed to online resources that are available. It may be worth considering having a reflux advice session by speech and language therapist, which would improve the compliance of the patient to anti-reflux medications and advice, and also provide voice hygiene advice for the laryngeal symptoms. The diet advice would include things to reduce the stomach acid production, like stopping spices, pickles, and mature cheeses, salt and caffeine and alcohol and smoking, to reduce intra-abdominal pressure, like reduce body weight and abstain from carbonated drinks or tight clothes, reduce gastroesophageal reflux, like bed elevation, and reducing vigorous exercise and avoid food within 3 hours from sleep time, and things to prevent lower esophageal sphincter incompetence, like stopping alcohol, tobacco, chocolate, and high fatty food, and finally measures to reduce stomach emptying delay, like fatty foods. And then, was the prescribed treatment adequate? The elements of adequate treatment for LPR include some or all of these: proton pump inhibitors, alginate reflux suppressants, antacids, H2 receptor antagonists, and diet and lifestyle advice. So a thorough check about the patient compliance with all these, and a check whether they are given the right dosage and for the right duration should be carried out. Most patients would have some improvement on these treatment in the initial 3 months, but it's usually about 6 months before the signs in the larynx and the pharynx also improve. If there is no response to such a treatment, to adequate treatment within 3 months, no response at all, there is no much need in increasing the dosage or the duration of these treatments. It's in fact time to consider whether the diagnosis is correct or whether you would want to add any extra specific medications. A study investigating the non-responders with 24 hours monitoring of impedance and pH, together in some cases with high resolution esophageal manometry, found that about half of the cases still have significant non-acid or weakly acidic reflux. About a quarter of the patient, 22%, had acidic reflux breakthrough, and therefore active reflux disease was noticed in about 3/4 of the non-responders. In addition, it found that 80% of the reflux episodes occurs during the upright position, and that when manometry was used, it showed a significant esophageal dysmotility in about a quarter of the non-responding patients. Gastroesophageal reflux disease responds quite well to the treatment with proton pump inhibitors, but the response of laryngopharyngeal reflux to proton pump inhibitors is at best variable. The way the proton pump inhibitors works in LPR is indirect. It's not a direct effect like in gastroesophageal reflux disease. It works by preventing the cleavage of the pepsinogen into active pepsin. Acidity is required to initiate such a step. So by preventing the acid production, it prevents the activation of pepsin. The divergent results of PPI in laryngopharyngeal reflux could be explained by any of these several factors. LPR patients are a mixed group of patients with symptoms affecting either the larynx, the pharynx, the aerodigestive tract, the chest, sometimes the sinuses as well. So there's the heterogeneity of the patient. Also, LPR is always overdiagnosed, with disappointing outcomes of acid suppression therapy as a result of treating some patients who may not have LPR in the first instance. There is as yet some unrecognized subgroups of patients with LPR who respond better to PPI than others. There is also a very high response rate for placebos in trials of PPI in LPR patients. In controlled trials, you would always see a very high response of placebo in the placebo group. This is possibly because there is a functional element in LPR that is as yet unrecognized, much like other functional gastrointestinal disorders who also have a high response rate for placebos. In addition, patients with non-acid or with mixed acid reflux of LPR reflux are resistant to high doses of proton pump inhibitors in more than half of the cases, and LPR patients require more aggressive and prolonged therapy with PPI compared to the gastroesophageal reflux disease patients. There are some subtle differences between different types of proton pump inhibitors, reflecting not only differences in the molecule itself, but also in the way it is metabolized in the body. Most PPIs will get metabolized within the liver through a certain enzymatic process dictated by genetic factors. So some patients, some races would metabolize the PPI differently and at a more rapid speed than others. Except for two PPIs, the isomeprazole and rabeprazole, that don't undergo metabolism through the liver. In many randomized controlled trials, some small differences between the different types of PPI could be seen in controlling not only the LPR symptoms, but also its physical findings. When a meta-analysis of these studies combining all these studies were carried out, it showed no real significant difference between the different types. But that's considering a large cohort of patients. There is no evidence of superiority of one PPI over another. But in individual patients, and sometimes it's useful to switch to a different PPI if a certain PPI is not giving the required response. Some patients may respond better to one drug rather than the other, so a trial of a different agent can sometimes be considered. An important cause for failure to respond to PPI in laryngopharyngeal reflux patients is when PPI is used as a single daily dose rather than twice daily. This was first noted by Park et al. In 2005, who noted that there's a significant failure rate with the use of a single daily dose of PPI, basically because the currently available PPI drugs only work for about 12 to 14 hours of each day, and because in LPR mucosal damage can occur with a very short-lived reflux episode, 24 hours coverage is necessary, so twice daily doses is necessary. Park et al. had a trial of two groups, a group with a single dose and a group with two daily doses of PPI. The group with the two daily doses had a 50% response rate within 2 months of using PPI. The other group with a single dose had only a 28% response rate. When this group had a further 2-month period of PPI with twice daily rather than their initial once daily, their success rate increased to 54% of this group. So the ultimate combined success rate for the whole group was 70% after 4 months of treatment with 2 daily doses of proton pump inhibitors. In addition, the PPI should be given more than 30 minutes before meals, either breakfast or dinner, and for a period of between 3 and 6 months. The PPI would reduce the volume of the acid reflux, but the non-acid reflux may still occur. The maximum anti-acid rather than anti-reflux treatment is a combined administration of PPI twice daily before breakfast and dinner, plus an H2 receptor antagonist before bedtime. And this mode of treatment would result in a greater acid suppression than previous medical treatments. The failure rate would still be significant, between 10 to 17%. Other medications are required in addition to the anti-acid suppressants in the form of, for example, alginate reflux suppressants. Alginates have been shown to be effective in the management of LPR symptoms, either taken alone or in combination with PPIs and probably H2 receptors antagonists as well. They form a mechanical barrier between the stomach contents and the esophagus. Thereby, they prevent the reflux from reaching the esophagus and can manage or help in managing things like a non-acidic or weakly acidic or mixed acidic reflux. They can also be used for breakthrough symptoms if the patient complains from things like cough or globus, and can be used just before certain activities that can cause reflux, such as vigorous exercise or even singing. But the usual is that alginate would be given after each meal and last thing at night. Other agents, like mucosal protective agents, sucralfate, would act by blocking the diffusion of the gastric acid and the pepsin through the mucosa of the esophagus or the pharynx, and can even stimulate mucosal growth factors. It's a safe drug with a good efficacy in controlling GERD and sometimes LPR symptoms as well. It has also the potential of improving mucosal healing. Because it is safe, it's the option of choice for symptomatic management in pregnancy. H2 receptor antagonists have mainly been superseded by proton pump inhibitors because proton pump inhibitors have a more potent action in blocking gastric acid secretion. But they may still have a role in patients who experience nocturnal acid breakthrough despite having twice daily doses of proton pump inhibitors. Adding H2 receptor antagonist at night time would help with the breakthrough reflux. Antacids have a proven, although a weak, effect in controlling symptoms of LPR. Randomized controlled trials show that they actually have better results in reducing symptoms and acid reflux more than a placebo. They are fairly safe drugs, but the aluminum-containing antacids should not be used in patients who have renal disease, and the calcium-containing antacids should not be used in patients who have hypercalcemia. The majority of LPR patients who are on the adequate proton pump inhibitors and H2 receptors antagonists plus alginate, probably with antacids, would respond to the treatment management after adjusting their diet and their lifestyle. A small proportion of the patient may require some long-term treatment, more than 6 months, but majority of them would need a step down. If patients don't respond to such medical treatment, or if they require long-term high doses of proton pump inhibitors to control their symptoms, they either need specific extra medications or consideration of surgery. For those patients who respond well to the medical treatment within 6 months, they should not stop their proton pump inhibitors dose abruptly because rebound symptoms are common, and stopping the therapy would initiate such rebound symptoms. For example, if the patient was on pantoprazole 40 milligrams twice daily, and then for 2 months he would need to half the dose to pantoprazole 20 milligrams for a further 2-month period, and finally pantoprazole 20 milligrams once daily for a final 2-month period. Then he would stop all the pantoprazole and would continue with some alginate and potassium bicarbonate 5 milliliters 3 times a day after meals, and he would take 10 milliliter of the alginate with the antacids at night for about 2 weeks to help in reducing his symptoms. Also may be advisable to supply the patient with some PPIs for ad hoc use, for example, before going out for a meal in a restaurant or after certain vigorous exercise. Most patients don't need to be on long-term proton pump inhibitors. Only a small number would need to remain of some maintenance therapy. But alginate and antacid and dietary advice are more suitable for the long-term measures in the treatment of responders, of patients who responded well to the triple therapy. Prokinetic agents were believed to be helpful in the management of GERD symptoms, particularly if dysmotility is an issue. It acts not only by improving gastric emptying, but also by increasing the lower esophageal sphincter pressure and improving esophageal clearance. However, a recent meta-analysis found no evidence of any value for adding prokinetic agents to proton pump inhibitors in the symptomatic control of GERD symptoms or LPR patients. So generally, it's not very useful in the management of LPR patients. Potassium-competitive acid blockers like vonoprazan are very efficient medications for controlling acid production. They are competitively inhibit the proton pumps, and they have been used for a good while in countries like Japan, for example, in the treatment of peptic acid and reflux. They can be more useful than the conventional proton pump inhibitors as an initial empirical test, and they have greater ability in suppressing acid secretion compared to proton pump inhibitors by blocking both inactive and active proton pumps. They have also a greater duration of action compared to conventional proton pump inhibitors. And its elimination is independent of the hepatic enzymes used for the metabolism of proton pump inhibitors in the liver. When available, vonoprazan is more effective than proton pump inhibitors in acid suppression. Another medication is GABA-B receptor antagonist like baclofen, which acts by reducing the number of reflux episodes, whether these reflux episodes are acidic, non-acidic, or even alkaline. However, they are particularly useful, of course, in the control of alkaline and weakly acidic episodes in combination with proton pump inhibitors, which would control the acidic reflux episodes. In addition to decreasing the number of reflux events, it also is helpful in reducing the esophageal acid exposure time and the reflux-related symptoms, both as monotherapy for maybe 2 to 4 weeks or in addition to proton pump inhibitors. The problem with baclofen is that it has a short half-life and poor tolerability. There are certain central nervous system and abdominal side effects like dizziness, like drowsiness, nausea, vomiting, or diarrhea. The recommended dosage is 5 to 10 milligrams 3 times per day, but with close monitoring of neurological and abdominal side effects. Among all of the GABA-B receptor agonists, baclofen is the only effective one for the recurrent patients with GERD or with LPR symptoms. Another promising medication that requires further evidence is metabotropic glutamate receptor 5 antagonist like mavoglurant, which acts specifically targeting the lower esophageal sphincter barrier function, improving its function and inhibiting transient lower esophageal sphincter relaxation, thereby preventing reflux. Another line of medications are the gastric-retained bile acids sequestrants. These are old type of medications that had received recently some attention. They act by binding the bile acids in the stomach, preventing their damage, the damage caused by the bile acids in reflux materials. Some preliminary studies have shown potential benefit in GERD patients, particularly patients who have refractory GERD symptoms that did not respond quite well to proton pump inhibitors. Kaufman suggested that the pepsin, which is deposited in the laryngeal tissues after reflux, can be reactivated by exogenous hydrogen ions rather than just the endogenous hydrogen ions in the reflux. They can also be reactivated by hydrogen ions derived from any source, including, for example, diet. He conducted a study including patients who were refractory to proton pump inhibitors, did not respond. He put them into a restricted non-acid diet for 2 weeks, and symptoms improved in 95% of them just by restricting the acid in their diet. He also demonstrated that pepsin can be irreversibly inactivated by alkaline water at a pH of 0.8. This suggests a therapeutic benefit of alkaline water in patients with reflux disease. If the patients continue to be non-responding to all medical treatments, or if the patients require long-term high doses of proton pump inhibitors to control their symptoms, then surgery should be considered. The main aim of surgery is to increase the competence of the lower esophageal sphincter and decrease any diathesis in the crury of the diaphragm. It involves one of several forms of laparoscopic fundoplication, but also new operations described includes endoscopic, transoral, incisionless fundoplication, or the insertion of magnetic sphincter augmentation, or radiofrequency therapy to the lower esophageal sphincter. Laparoscopic fundoplication is now well established in the surgical treatment for gastroesophageal reflux and produce reliable results. But its role in the management of laryngopharyngeal reflux is still uncertain. Surgery has been shown to produce better results in patients who have gastroesophageal reflux symptoms, as well as laryngopharyngeal reflux symptoms, and those patients who have positive findings on the pH monitoring, and patients who responded well to proton pump inhibitors. But Satalov had showed positive results as well after surgery in symptomatic patients due to non-acid reflux, in addition to acid reflux in those groups of patients. By this, we come to the end of this presentation on the management of LPR patients who don't respond to the standard medications. Assalamu alaikum.